So I am Dr. Inderdeep Singh. I come from Amritsar. So starting the case history, this 16 years old male who was an NDA aspirant and a right hand dominant, he had a right shoulder recurrent instability. It started 1 year back when he presented to us after a fall on outstretched hand, and it was reduced in emergency without GA. So till he presented to us, he had around 6-7 episodes of dislocation, which was self-reduced, and later he also had a sleep dislocation. So his clinical examination, his Baton's was 6/9, apprehension test was positive, relocation, all the tests for instability examination were positive, especially the bony apprehension test, and the Gage's hyperabduction test was also positive. So these were his x-rays, and we were happy to see the general normal views we take for every patient. And these were the MRI, and MRI revealed good Bankart lesions and Hill sacks. So these were clearly staring at us, and we were happy that he has a simple Bankarts with a Hill sacks. So, and then we do CT scan for all our patients. So this is how it was done. We do a 3D recon subtraction view as well, and do the calculations on the console. So his bone loss was around 17%. Hill sacks were the following dimensions. It was an on-track lesion. So this was his CT report. Our radiologists are not very happy mentioning the amount of bone loss. They just give the simple CT report. So, but we have to do the calculations by ourselves. So here comes the ARS1. So what will be the plan of treatment? So I think there is no other option than this. I think everyone chose this. So I also chose the arthroscopic Bankart Remplissage. So same plan for me. So this was so it was the first case on the morning, and we went in and we saw a good juicy Bankart lesion. So when I switched the scope to the anterosuperior portal, I saw something unusual. So this muscle was staring at us, and I think I never seen this, and there was a big Hill sacks defect here. So I was bamboozled. So what's wrong there? So I went back and looked at the MRI. Look at the MRI report. So it again said anteroinferior labrum tear. So what to do next? So this was the MRI. So I just keep on gazing at it, and then I saw there is something wrong there as well. So this it was a floating anteroinferior glenohumeral ligament, so which was torn at both the ends, from the glenoid side and the humeral side, or it was a Bankart and a Hegel lesion in combination. So this brings us to ARS2. So what will you do now?
Can you show that video again?
Yes.
So that's from the anterosuperior portal.
That's from the anterosuperior portal.
Okay.
So once I moved my scope there, then I saw this. You want me to replay it, sir?
Please. So everyone is confirmed that there's a Hegel lesion there?
So I had never seen it before, even during my training. I don't think so I've seen it any time, and it was all on the videos which we saw that this is how it looks. So it's kind of thing like what our eye sees, what our mind knows. So I was not happy with this muscle which was peeping out and staring at us. So this is a standard Hill sacks. So if we move on to the, so my plan was the same, to do an arthroscopic Bankart repair, Hagel, and a remplissage. The only thing was I had never done a Hagel repair before this, and this was the first time, and all the three things were there. So, so if I go to the intraoperative video, so this I just started with putting in a screw for a anchor for a remplissage. So which was again seen from the anterosuperior portal. I put a double loaded 5.5 anchor and made a passes through the capsule and the muscle and the tendon. So it's a standard remplissage procedure which we do regularly. So, and then this was a thing which I thought I have to bring it back to the humeral head. So this has to be lifted off and put onto the humeral head here, somewhere here. So how to do it now? So this is how we do it. So we made a trans-subscapularis portal, so through which a sleeve came in for putting in an anchor onto the anterior or humeral neck there, and it was a double loaded anchor. So with a lasso we have to make a pass into that area. So this trans-subscapularis portal should only be used to put in an anchor, and then with the nitinol and or a proline you have to suture the shuttles. The difficult step here is to feed the sutures into the nitinol wire, which has to pass through the tissue. So alternatively it has to be done and suture has to be parked. Otherwise there will be a lot of entanglement and you can get confused. Again with the lasso we have to pass another proline or a PDS to shuttle the sutures through the tissue. So this again there can be some scuffing of the cartilage, which happened with me as well. So it's imperative that you should have a good distraction of the glenohumeral joint. So once you have made the passes, then you can start doing the knotting. So that's how we knot. The problem here is the space constraint anteriorly, so which is difficult to visualize at times. And once you are done with the knotting, you can just simply cut off and you can see the tissue moves along with the humeral head. So then we simply proceed on to complete our labral repair or a Bankart repair, which follows the same step. The only problem, the challenge here was how much tension is good tension, and we have to simply repair it back to the glenoid. Otherwise we can rip off the entire repair which was done on the humeral side. So this is a standard Bankart repair with a all suture anchor, double loaded suture anchor. So once we have passed on an anchor, we shuttle the sutures across and do the knots. So in this tight glenohumeral joint, it was difficult at times because you need a good glenohumeral distraction. The capsule may not be voluminous like in standard instability cases. So that's how we do the standard Bankart's repair. So these are the portals which were made for these patients. So there were just a posterior portal and incision for a remplissage and a trans-subscapularis portal which helped me in repairing the Hagel lesion. So the challenges here were the space constraint. Patient was already in the lateral position, so I thought of opening up on the humeral side to do the Hagel repair. The other challenge is difficult to get a trajectory for the anchor insertion on the humeral side. When you are doing it arthroscopic, there can be a lot of suture entanglement, and there's always race against the time. So the intraoperative tricks come here is you should have a strong assistant who can actually distract the glenohumeral joint. Need a curved sleeve for an all suture anchor to be inserted. Trans-subscapularis portal, it should only be used for anchor insertion, and sutures need to be fed to park them in the posterior portal, and always have a flow suction, otherwise your anesthetist can always make fun of you. The rehab followed this. He had elbow pouch for 6 weeks, and shoulder isometric started on day 1, neck, elbow and wrist movements were also started, and standard phase 2 and phase 3 rehab was followed for as we follow for shoulder instability surgery. So after 8 months, he dislocated his left shoulder, which was the first episode of dislocation. So I didn't hesitate to wait for any other episode to happen. I went ahead and did a arthroscopy Bankart repair and remplissage on the other side. So following are the post-operative movements. So he had full total elevation, good external rotation by side, more on the right side. He was so it was less time on the left side, so his rotation was lesser on the left side. So even external rotation was good in abduction, and internal rotation and cross-chest adduction was also good. So the post-op MRI was done, which was done last week. So just to look at the healing. So this was the healing of the Hegel and the Bankart on this side. It was healed, and we can see there is no hyperintense signals. So if I look at the review of literature, I went back and tried looking for the lesions. So Hegel lesions, they constitute around 9.3% of patients with recurrent instability. Anterior Hegel is more common out of the Hegel lesions, but incidence of floating IGHL is around 22%. So there are two different type of attachments of the humeral side of the glenohumeral ligament. So it can be collar-like attachment or a V-shaped attachment. So this is a normal arthroscopic anatomy, and this is a Bankart lesions, and when we turn our scope to look at the humeral side, so this is how it looks, and you can always see a bubble here, which can give an indirect evidence that there is no avulsion of the humeral side of glenohumeral ligament. So there were few case reports, but most of these case reports, when they had a Bankart and a combined Hegel lesion, so they have done a mini open kind of repair in all of these case reports. So the disadvantages of open procedures, maybe it needs a meticulous dissection, and subscap needs to be separated from the capsule. Otherwise you cannot see the Hegel lesions, and it may need an excessive retraction. So there's only one case report which comes from Ejitoi group, which says they have done an arthroscopic repair of Hegel and Bankart. And they also missed the diagnosis when they were doing, because there was no J sign, which is classically seen in a Hegel lesion. And so one should have a high index of suspicion whenever they are looking at an unstable or a dislocating shoulder. So there is no consensus regarding the optimal surgical treatment of these lesions, whether do it open or arthroscopic. So this comes to ARS3, because I would also like to learn from the masters. What will you do in such scenarios when you get a surprises in your during your surgery, when you have planned for something else and once you go in and see something else? So I have a lot of experience and senior surgeons here who can tell me from their experience. So just do what you know.
I think what's important over here is diagnosing, to have this thought that this patient is having Hegel, and then really expanding your arthroscopic skill to repair the lesion.
I'd like to make a comment.
Well done. Yeah.
Well, first of all, congratulations for the technique. I think it was a very good solution. Regarding the struggle you probably felt regarding the room you had for the procedure, I don't know if you completed the remplissage before going to the anterior part. As far as I understood, that's what happened during the technique. So probably that would have made the joint less spacious for the anterior procedure.
No, for remplissage, I just passed in and parked the sutures that were noted at the end.
And you tie them afterwards?
Afterwards.
Ah, okay, okay. So, and a comment regarding the indication beforehand. We know that in such a patient at 16 years old, into the army, I suppose, right?
He's an aspirant.
Yeah, okay. Anyway, well, I'm an army doctor, so I deal a lot with these kind of patients. And besides, is a 6 out of 9 of Byton score, so close to some laxity dash hyperlaxity. So the risk of recurrence of this patient with plain simple plication and Bankart repair is already very high, not to mention if the Hegel is associated. So one must not forget that the risk of a soft tissue procedure in this patient has a very high risk of redislocation. But still, I think it was a very good solution once you bump into the case, into the lesion in the OR.